Matthew, thank you for making the time to connect. Really appreciative. I've been an admirer of your work for some time now. I discovered you like over a year ago, but I've come to learn it's been decades that you've been doing what you do, which is really now, as far as I'm concerned, and I know many people, as I've kind of talked to others about you, you're my go-to healthcare journalist, and that's not an overstatement. Maybe if not a day, certainly isn't a week that I'm not consuming multiple pieces of your content across multiple mediums. As I said, I'm particularly fond of you on LinkedIn, but I've captured some of your longer prose on your blogs, Substack, and I think those are really deep and incisive. And you have deep knowledge and a deep sense of comedy when it comes to healthcare. And I find that, I'm reading something serious, a serious take you have about whatever merger or IPO, and then you close it with like an edgy, spithy kind of, historical reference to something that went wrong or right in healthcare that really only those in the know. And it's enlightening and it's also enticing. And you have a great way about you. So I'm excited. We're meeting for the first time. You're on the West Coast. I'm on the East. You were very kind to make time, reached out. So I am grateful that you did that. And I'm looking forward to an extraordinary conversation with really one of the best minds in this. And so for those who haven't read or followed Matthew, I encourage you to do so. It's like I said, it's quite a treat. So thank you, Matthew, for taking the time.
Z, thank you. It's a real pleasure to meet you. And, I'm always enthused by people who are trying to fix primary care, early stage, the organization delivery of medicine to make it better for consumers and patients. So, you're absolutely in the right space. And I appreciate all that stuff you said, even if it's probably not true. And don't let a real journalist call me a journalist. Here, you call me a journalist, they'll get insulted. But I think the moniker of being a blogger was a good one. It's a pity that there aren't, the blogging is kind of died-ish, but anyway,
Yeah.
all good fun. But yeah, you can find me trying to be thinking that I'm funny, whether I am or not, and trying to skewer people on LinkedIn and a little bit on Twitter still. But Twitter is not what it was, sadly. But there we go.
Right. Well, I do want to cover like some high level topics. I deliberately didn't go into this with too much because knowing you, at least through your writing and interviews, I know you have a lot to say and you have kind of a stream of consciousness that I admire, and I didn't want to be obstructionist. And so I have some, seeds I'm going to plant, but by no means do I have a direction in particular that I want to go. I'd rather follow your intellect and creativity. So, the first thing is it's very high level, it's broad, but I think, again, with someone like you, you can work with it. You've done, you reviewed in the past couple of decades almost everything that's gone in healthcare and call it fads or breakthroughs, many more fads than breakthroughs. And you've spoken to leaders or would-be leaders. You've seen, the fake, the real, and you've done it also from multiple perspectives. You've consulted for folks, you've seen them from afar, and you've had really what was for a long time the go-to healthcare conference where you were kind of the mediator, the referee. And so, not only the duration you've done this for, but the fact that you've had different perspectives, I think makes it a very unique kind of perch that you've sat on. And with that context, with that background, I'd like to ask you, like, right now where we are in healthcare, the right now at any point seems like the only moment, seems always, as the most special moment because it's the moment we're in, right? We forget very quickly that 5 years ago we felt we were just as excited, and that 5 years from now we're going to be just excited. And statistically, 99% of the time, there's no reason to be excited, right? But we don't get that, and so I want to take your perspective, your individual context that's so unique, and ask you AI right now. The administrative changes with Trump, right? Like, the RFKs and the Mehmet Oz's and blah, 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 this, that. Also, the consolidation that's happening throughout healthcare, which has been happening, but just happening at such scale. What is it that you see that it tells you, you know what, Z, it's a lot of noise that's going to take us nowhere better than we are? Or you know what, here's kind of a canary in the coal mine, the AI stuff, or actually the administrative changes, there's some positive here. They're going to flip the table upside down, and they're going to break a lot of things they shouldn't break, but it's going to set us on the right direction in terms of big pharma or whatever. I know it's a way nebulous question, but I just want to start there.
Well, let me quickly pick those three, because I think you identified the three super things. So I was at a conference last week called put on by a VC in San Francisco called AI in Healthcare, and everyone was getting super excited about all the stuff AI was going to do to administration and clinical care and patient outreach and all that stuff. And I'm deep in the mires of that with a couple of companies I'm working with, and the amount of confusion about what does AI do, what are these large language models going to be used for, which aspects of healthcare are they going to really change, how quickly, are we going to replace psychologists, are we going to replace nurses, are we going to aid doctors, are we going to replace doctors, that conversation is right at its frothiest peak, and there's a lot of confusion. A lot of companies have raised a lot of money and are rolling out products. Obviously, NVIDIA is having its year in the sun as being the stock we should have bought 3 years ago when we weren't paying attention, and it's far in excess of the last very big fad, which was blockchain in healthcare, which was going to change the way that we calculated and exposed data and all that stuff, which didn't happen. So that I think is a big piece, and we should definitely pay attention to it. I know you've had Robbie Pearl on the podcast, and he says he thinks that that's now going to be the ability to manage patients, and both he and I and many others have talked about this idea about how do you get remote patient monitoring or consistently ongoing 24/7 monitoring of the chronically ill, and start seeing patients who get out of whack, and how do you support them using these different tools, both a combination of monitoring devices, but also monitoring soft technology, that's attached to a kind of knowledge base that ChatGPT or whatever digs up. And I think that is a big potential deal. However, it takes a very long time for any of this stuff to work its way through the healthcare system, predominantly for the reason that we have not figured out how to pay people like you, doctors, health systems, any differently now than we have done since back in the 90s. Lots and lots of talk, and my friend and quasi-mentor Jeff Goldsmith tells me all the time, value-based care is this great program for consultants. It doesn't actually change how we do health care. Man, it's value-based consulting, very big dollar consulting, but we haven't, we really are only paying. We're still predominantly paying fee for service to the vast majority of doctors and hospitals out there, which is why you see private equity folks get into the room with healthcare providers so often, and why you see for-profit hospitals still doing very well if they're very focused on doing procedures and doing infusion and doing chemo, which is the three big things to make money in healthcare. Sadly, pediatrics is not one. I think you probably noticed that.
Yeah, that's right.
So I think that AI piece is bubbling. It's ripe for doing a lot of different things, especially in the back office. There's so much annoying, procedural crap in contacting doctors, contacting patients, doctors contacting health plan, all the rest of it, that really could be done so much better. You just see the new companies come out to do that stuff, which will, even if they get it 30 to 40 to 50% right, that's probably better than the experience for most patients and most doctors. You have people sitting in, I'm sure you have this in your organization, people sitting in doctors' offices in the back room there, on hold with an insurance company trying to get some pathetic thing answered if they could just get a bot to do that for them. They were talking to the insurance company's people and let the insurance company's bot, you get a lot done. So I think that is one big area where, it looks like something's happening, but it's probably not as quick as the hype would say, but there's a lot of, areas where you can get good shots on goal. The second part that you mentioned, right, which is sort of consolidation of health plans, there's a lot of fuss, especially from, I would say, private practice docs who are now in the minority, about how big hospital systems and big private equity-backed medical groups or private equity-backed medical groups are kind of squeezing them out. And I think it's true. And I think we've done a lousy job protecting the interests of private practice doctors. However, I think this is the culmination of a long-term trend that's been going on, really since the 60s when we first started with private for-profit hospitals. And what the growth of HCA and then later climbed to HCA under the now senator from Florida,
Right.
the former governor of Florida, who somehow, is in the Senate complaining about fraud, but he ran the biggest Medicare fraud of all time. But let's ignore that for a
Yep.
second. The growth of that, the growth of that company over the years has been, and others like it and a combination of other things, has pushed non-profit systems to start acting like for-profit systems. So you have these big system organizations who are designed to suck up primary care groups, suck up specialty groups, and all the stuff that goes around it in order to feed the big profitable service lines. Yeah, the cardiothoracic surgery, the orthopedics, the general surgery, the neurosurgery, all that. Yeah, infusion, oncology, all that good stuff that makes them all that money, right? And they've been very successful in general at doing that and building these huge organizations. And you know who they are. There's probably 2 or 3 in each market, and they've been merging over the years, and no one's really stopped them. So I don't see that going away for a while. I believe those big health systems are poorly set up to do what we need to do in terms of managing patients. I have this spiel and chart and piece I've written up called the continuous clinic, which is all the things you would put together if you wanted to manage patients wherever they are. I started doing this during COVID. How would you put together a combination of devices, outreach, telehealth, staff, virtual staff, AI-driven staff, but also AI-driven algorithms and management to sort of figure out, okay, we've got a patient in the home. They're basically okay with their diabetes, but they're trending out of whack, and can we do something about it? What interventions can we make before we have to put them in the hospital? The problem is I don't think anyone's set up to successfully manage that process, and no one really seems to want to take the job on. We'll see about that. But, I might be wrong. So that's the second big piece. And then you mentioned, obviously, the upheaval we've got with the current administration. I mostly see them trying to break things, and I think it's mostly a power flex. I think the politics of this exceed the policy. And I'm on record as saying I think it's terrible for America. However, you're going to see if we can somehow rationalize the process at FDA to get, maybe less in the way of stopping new drugs and stuff coming to the market, maybe rationalize what's going on within CMS, make it less confusing. Instead of having, 15 or 20 programs for value-based care, have 1 or 2 and expand them across all of Medicare Advantage. Maybe if they are really aggressive, going back to the research hat you mentioned, and I'll shut up after this, having a good look at the underlying conundrum of Medicare Advantage, which has been growing like a weed for the last few years, last decade or so. Nobody actually knows, does a patient going into Medicare Advantage cost the government and or the patient combined less, or does it cost them more? And you've got MedPAC on one side saying it costs you 5 to 7% more, and you've got the Medicare trustees and a bunch of people like Lewin, who admittedly are paid by the Medicare Advantage plans, saying it costs you 5% less. And no one can agree on this number. It just blows my mind that we haven't figured out which one of these two should we be doing, and how should we be reforming the way we pay Medicare and Medicare Advantage to drive people to lower cost care, because, we're spending 18% of GDP and everyone else is spending 12. So maybe we'll get something go. I kind of doubt it, but I'm fingers crossed that, Amy Gleason, who is at Doge and, is coming to CMS, and Brad Smith and people like that who are involved in that might start looking at that with Oz. Yeah, we'll have to see. There are some good people potentially in the CMS world. I despair a bit about what Kennedy is doing with, he's also on the wrong job. He really cares about food. So issuing the agriculture job, because that runs food in America, not HHS. But
Right.
I don't think we're going to fix our agriculture, but I actually agree that we should get rid of, high fructose corn
Yeah,
syrup. I think it makes Americans kids fat. And if you go to Europe, you don't see it.
right.
But that's way outside the scope of what he's got, let alone what I know about. So,
Well,
so a bunch of stuff there. I probably said way too much, but
no,
hopefully
not
that
not
gives you
not at
something to
all.
riff on.
I think you touched on everything with exactly the pressure that I think it deserves, and the nuance and respect for the potentiality of good, bad, or indifferent outcomes. And I think anybody who comes in definitive at this point, it either is the most brilliant person in the world or has no idea what they're talking about, right? But I think I think when I'm listening to you, Matt, the through line, like if I take like, okay, for the AI piece, you know what? There's a bunch of crap in the middle of healthcare, prior authorizations, getting the revenue cycle thing, checking eligibility, blah, blah, blah. That's prime for disruption with AI, right? It's a bunch of, you said it perfectly. There's three in every doctor's office. You wonder what's that office in the back of the office with four people just sitting down, which didn't exist 20 years ago. It's because of all the bloat and administration. And so it's a disaster. And so that should be AI'd. Then we talked about like the consolidation and and what's happening there. And if, you know, when I think about that and now with the new administration and where there's opportunity on research and protocols and clinical pathways, and you talked about Medicare Advantage and why we can't read the data. The one thing, while I think technology can come in, and AI, when I say technology in this case, I mean AI, can come in and you can have really smart people who could do some language learning models and sick them on these problems, right? From a distance, and even from a medium distance, problem X is solvable with AI. But my concern, and this is what I want to hear from you, kind of cutting real deep on this, is we've thrown a lot of stuff at healthcare. We've thrown a lot of potentially rational solutions that would work. Like when you look at the problem, you say, "Oh, here's a problem, eligibility," or "Here's a problem." The trend of healthcare is going up. Like when you talk about Medicare Advantage and risk and so on. But no matter what, the beast that is healthcare manages year after year, despite technological advance, despite brilliant people coming in, to accomplish two things: to accomplish a trend in rise in costs that's no less than 5% on a good year and higher on a bad year over year, outpacing inflation and cost of living, year over year unequivocally, and getting worse outcomes for that. So we're throwing stuff in healthcare, we're driving cost up, and we're driving outcomes down. And so it's a beast, right? It's like this undefeated monster of evil, in a sense, that it's able to relentlessly increase cost without improving clinical outcomes. And so makes me think that no matter how brilliant the technology is and how unbelievable AI is, why is that? And where my mind goes to when I hear the anecdotes you're talking about is misaligned incentives. And as long as the incentives are not aligned, then no matter what kind of, topping you put on it, right? It's gangrenous in its core, right? No matter how much you try to like pretty it up. And so take one of the examples you gave just to get specific on it. If you think about like the hospital systems, the consolidations that's taking place, right? And you say, well, AI can come in and you know what? We could intervene when that 73-year-old who has COPD and heart failure, we could intervene to make sure that just when his blood pressure is tipping over, 3 days before he's having a cardiovascular event, we could intervene. That wearable can notify our ICU nurse and catch him before he's in the ICU. That makes all the sense in the world. The problem is the decision makers, right? You might have two kids from Stanford who produce that technology, right? But then they sell it to one of the decision-making entities, right? These hospital systems now have VC incubators, right? Like you see that, right? Like the Mount Sinai's and the University of Pittsburgh's. I woke up 5 years ago and all of a sudden they're incubating and they have VC arms and venture funds, right? So they get in there and or one of the insurance companies gets in there and then it dies. The thing dies because they get in there and the decision makers are like, wait, let me look at my P&L. I make money by making sure this guy gets into the ICU. I make money by making sure the guy gets on insulin and so on and so forth. And so I don't think I'm overstating it by saying if the incentives stay misaligned, right, and the people making the money at the top have misaligned incentives, I don't know how you could really, really use this stuff to disrupt and deliver the care. And the track record speaks for itself.
You're so right. And my friend and colleague Michael Millinson wrote the book called Demanding Medical Excellence in 1998. And he one of the things he did in this book was he interviewed Brent James, who's a legendary head of innovation and clinical quality at Intermountain, right? One of the most forward-thinking systems, the kind of Kaiser Permanente of Utah. And, in general, Intermountain had the luxury it's owned by this even bigger, richer organization called the Mormon Church. Well, not officially, but it's owned by a big, rich, powerful, cultural, very strong cultural organization. And yet, eventually Brent was like doing all this great stuff and, figuring out how to catch stuff early and get people out of the hospital and not them into the ICU. And eventually gets a call from the CFO who says, by the way, you understand all this stuff? When you do this and you get this person out of the ICU 2 days early or whatever it is, you're costing us $22,000 per admission. Can you stop it? So that problem hasn't gone away, right? And you still have things like, we haven't mentioned it, but hospitals you get they buy a physician practice and all of a sudden becomes a hospital admission, when someone shows up there and they get, non-site neutral payments and all this stuff that gets discussed. So there's all these weird incentives, right? On the side, there's a lot still, and this is in tiny markets all over healthcare, but, I just read a whole bunch of stuff from Clear Healthcare Costs on the wound business and how people manage to spike the payments for different types of wound care. You've got any number of games being played in the world of drugs. The fact that Humira, I always say we have a ton of innovation in our pharma business. The problem is innovation in patent law extension.
Right.
We have great law. Yeah, I don't know what our scientists are doing. It's costing them billions more to produce new drugs. The rate of money in for R&D per new drug is going completely the wrong way.
Yeah.
But extending patent life incredibly well. And we're seeing this with GLP-1s. Like, what can we do to have this amazing new drug and make sure that it's very expensive, and we're spending gazillions of dollars on it. So I look at it and go, we've got so many pockets within healthcare where people can make money that you're almost at the point where it's as you said. That's why things are getting up. The good news, quote unquote, it's not great news because of what's about to happen, I think, is that for the last nearly decade and a half, healthcare has stayed at the same rate of GDP. But that's because GDP has gone up pretty much consistently every year. And the 1 year where it went down, which was the recession year of the COVID, 2020, it shot up from 70% of GDP to 20%. And then it went down again because the rest of the economy caught up because we stuck a huge amount of money in the rest of the economy. Right. And at some point, we're going to have, whether induced by Trump and tariffs and God knows what's going on, the craziness is going on now, or just by something else, we're going to have a recession and then it'll tick back up. And then, we'll see whether we can do anything about healthcare costs, and how we do it. I suspect that is, that's a big problem. And the other thing we've done, and maybe AI will fix this, it's a big maybe, is that we've loaded lots of point solutions onto doctor practices, physician practices, and the health systems. So everyone's loaded up stuff. We put the EMR in everywhere, which is track stuff for billing. And it, I think it's better than it was in terms of at least knowing stuff, and we should be able to see what's going on. But we haven't quite figured out how do you layer technology that actually increases productivity. If you go back to the introduction of computers in business in the 1990s, it took about 10 to 15 years for us to stop doing stuff. At some point, we were just creating more paper and sending more stuff around. And then eventually, ways of business changed, and things like the amount of mail being sent started falling because people started getting bills electronically and paying them online. We started, the people working at in telecommunications went away, and the cost of that went away because we ended up having more and more communication, using computers. Skype kind of killed long distance calling. And so you did start to see the economy change. Then, of course, you started seeing, retail change because of Amazon, and entertainment change because of Apple, iTunes, and Netflix, and what have you. So you started seeing all these changes in the economy. You haven't seen anything like that yet in healthcare. And you are part of that, right? Can we figure out a way to deliver consumer-friendly, more effective, primary care and managed secondary care better than we've done before, rather than the mess that currently exists that you and I know, and anybody who's, especially anybody who's sick, knows when they have to get in the healthcare system and they self-direct, what you might call the self-directed, choose your own adventure, that when they have to try and figure out which specialist to go to and how to get, how to get sure that specialist A accepting them is the right specialist, is in their network, how much they're costing, do they have a surprise bill coming from the fact that they had a procedure and there was somebody in the room who they didn't know
Yep.
was going to be there, yeah, et cetera, et cetera, et cetera. And did it make them better? And was anybody paying attention? To me, that mess is continuing on. And that's the thing that, for the consumer experience side, one of the many things we have to fix. But you can imagine that being done with some of these tools. But as you say, we don't really have the incentive for anybody to do that at a large level. I'll just close this by saying I had a conversation with Anish Chopra, who's very smart about this topic. If you haven't had him on your show, you should get him on your show. Anish knows a lot about a lot, but one of the things he's been looking at is the data around Medicare Advantage. And he said, I think that Medicare Advantage, for doctors who are paid by capitation by a essentially global budget, his data is now showing that he did a big study. His data is showing that they actually, on a bunch of quality measures, do better for that section of their patient population than for the same doctors dealing with Medicare Advantage patients who are just paid straight fee for service. The problem is the data from Humana doesn't show that they're actually, even for the ones Humana pay, quote unquote, full capitation value-based care, doesn't show them being any cheaper than the ones who are paid fee for service. The Humana pays for fee for service. So we have a way, again, before, the data starts showing what I think we kind of all believe, which is that, managed, well-coordinated care using technology is better and cheaper. It just doesn't seem to be showing us yet. So, I don't have a good solution for that. And I can't tell you if that is 1 year away or 15 years away.
And Matthew,
I would end by
no,
saying
please go ahead.
that my
Please go
last
ahead.
comment thing is that 25 years ago, my mentor, Ian Morrison, who sadly just passed
Sorry to hear
away,
that.
ran a big study on the future of mail. And this month or last month, Denmark has decided to stop delivering letters. Their mail services say, we're not doing letters anymore. No call for it in Denmark. So eventually these things go away if you can replace them with technology.
Wow. Oh, so
Eventually.
no mail, like any mail or just letters?
No letters. So I think it's because, most letters are bills and almost all bills are electronic, and they're saying, I don't know. I actually went to Denmark 3 years ago on vacation, and I sent some postcards that cost them like €5 each. I mean, really expensive, back to the States. None of them got there. My wife took a bunch of photos and went to some postcard app that generated a postcard for like $1 each and sent it within the US, and they all got there.
Oh, wow.
My attempt to get a Danish stamp on the post office didn't
All
work.
right. So some of our stuff works better, I guess, if not our healthcare system. Matt, just on the point, you made a couple of really interesting points, and I want to go like slice just one bit deeper. I want to pull a couple of those things out that resonated. And we have a lot of people who listen and watch that are actually themselves in healthcare. And, the point solution comment, I think, is something that's overlooked as like this emerging problem. It's like, 5 years ago, 5 to 7 years ago, it was like, that solution looks good. I have this problem. I'll just take it. That other solution, my EMR doesn't talk to whatever, my PAC system or whatever. Now, what most doctors are seeing is that there's this technological bloat where a lot of doctors have 7 different healthcare apps in their business that they use, and like 12 different, third-party RCM, blah, blah, blah versions, and then 6 different insurance layer, like on top of their RCM, whatever it is. And all of a sudden they have all these point solutions. And now the biggest problem they have is the point solution problem. Like, how do I get these things to communicate? Right. And so I think one thing you said, and what we're trying to do is, I think the hard part in healthcare is it's impossible to look at the whole system and the whole problem and say I'm going to solve the whole problem. But I think it's also not as valuable to say, and this is kind of the anti ethos. You're out in the Silicon Valley area. This is the anti Silicon Valley thesis, which is often they'll say pick one problem and solve the hell out of it. Well, I think in healthcare, there's been examples of that. And it doesn't reap the same benefit because in other systems and under other industries, that one problem is often not surrounded by 6 million problems. It's a stable kind of foundation. And so when you solve that problem, there is an unlock. The problem is this one problem is part of 6 other problems. And I think that the guy who comes out of Silicon Valley sometimes doesn't see that. He's like, look, I solved that problem. You told me that was a problem. And you're like, yeah, but you didn't let me finish my sentence. There's all these other problems that come with it. Right. And so one thing like we're trying to do, and I think this is an approach. It's a lot harder. Is say, well, let's look at the primary care problem. Like within primary care, there's a million problems. There's access. There's whatever out of network. There's, it's not holistic. It's too medical interventionist. We prescribe too much. Whatever. And so, like you talked about how it's almost like a hellscape when a patient has to go to a specialist. It's like I don't know who I'm going to see. You don't even. It's gotten to the point you don't check the quality of the guy. You're like, he'll see me in under 3 months. Boom. Let me ask questions later. I don't even know if he went to med school, but he's seen me under 3 months. Cool. I'm ready to go. So well, I look at that as a primary care problem, not a specialty problem, because primary care should point guard that, right? We should be navigating, controlling, and using our leverage to benefit the patient. And then you talk about access. Well, I think access starts with the primary care, right? We point and we say, well, the ER, there's overutilization. I don't look at ER overutilization as overutilization. I look at it as primary care underutilization. And we should point the finger at ourselves for not being there when the patient needs us necessarily. And all of a sudden, what we're trying, what we're trying to do is say, all right, well, let's tackle access, but in the broadest definition, not, hey, we have an access thing where you can text us. We have that, but that's one thing. But then are you available 7 days a week if you need to be seen? And if you are available 7 days a week, are you really? Meaning just because your doctor's in the office 7 days a week doesn't mean I can get in to see him 7 days a week, and really sit and go deep on accessibility and then the workflows. And technology is a part of that. Technology greases those wheels, right? Maybe you have like flex schedules, like the AI. We're actually using AI where behind the scenes, when we get inbound and we see like what are the office slots, right? Okay, you have X amount of office slots and we have certain service standards. We don't want there to be a wait time. Well, 50 to 60% of the inbound visit requests can be done easily virtually or in person. Sometimes the patient prefers in person and sometimes they prefer virtual, but probably half could objectively be done at a high standard that way. So if the offices are packed and then our system advises our team that this should be pushed to virtual, you're able to see the patients and actually do so by maintaining service. And this is just one like very nerdy example where you go deep and you take the technology, you take the labor force, you take the brick and mortar, and you say, sit on access, sit on the word access. Don't run over it in like a quick sentence at the end of a McKinsey report and say, access is a problem. Like, and there's ER, but sit on it and just take extreme accountability from a primary care perspective and pretend nobody else in the world exists. Just do that exercise. And then all of a sudden you're actually able to make some magic, right? Where you actually are able to see folks whenever they need to be seen. And more importantly, you can leverage so you can get the proper access with the proper specialists on their behalf, right? And then all of a sudden you look at what happens. Nobody's going to the ER because we know 82% of ER visits are unnecessary and they're there because they couldn't get to their doctor. And all of a sudden you're solving even more than the problem you set out to solve, right? Because you really understood that it shouldn't be just a point solution, right? It's almost like a thematic solution, right? And I think that's unique to healthcare. And so I don't know, I guess it's not a question, but like, do you see AI pulling these point solutions together that don't talk to the ER and their API doesn't go into Athena, but it goes into Cerner?
Yeah, the answer, I don't know. The answer is that we have so many little teeny problems. I ran into a company not so long ago, late last year, that was doing tracking the hours and licensure of therapists in mental health who are required to do a certain amount of training
Right.
and before they get certified to join a work. So forget tracking signing up therapists to the network, for a health plan or a medical group, whatever it is. But this is like, can I accurately train and, certify that the right training was mentoring and training was done, and they provide the mentors. So right now there's this messy thing of people, if new therapists, newly trained therapists, finding their professor or somebody to mentor them and give them half an hour every week or whatever they need to get done, and somehow sign it off and somehow qualifying and somehow certifying. This company takes that problem, fixes that little problem, and then says this person is qualified and I can stick him in a network, right? And I will credit all the credentialing and continuing medical education. I mean, and you look at mental health as a whole, and go, that is a tiny
Right.
slice of one tiny part of the problem,
Right.
but
Right.
yet it's got to be fixed, right? So do we get rid of all point solutions? Well, that's better than what's
Yeah.
happening now. But is that
Fair point.
is that something that we can get rid of?
Yeah.
So I have that. On the other hand, and this is what both NVIDIA and I was going to say Nadella or Microsoft, but it's actually not. It's blanking on the CEO of Google's name. What is the CEO of Google's name? Of Alphabet's
You
name?
mean
Oh, I'm blanking on his name. Oh, anyway, I think it's Nadella at Microsoft who says that he thinks that LLMs and the new AI is going to replace SAS, and you're basically going to type you're going to prompt in some way the LLM, and it will come. They'll figure out the new interface layer and it'll go off and fix your problem, which currently now, so instead of saying, open up the whatever point solution is helping this little part of access, you'll just tell it, okay, here's what we do for access, you go figure it out. And if you can do that and have access as a lens by which you look at the entire, patient journey experience coming into your primary care group, and then it can figure out, okay, well, this person needs this. They don't need a doctor visit. This person is liable because of what we know about them to go to the ER. And here are the 4 interventions we can do right now that will fix that. And the 5th one that, may escalate that up to a visit to the person's home if it's that, whatever it's going to be. I can imagine somebody as smart as you managing a system or creating a system with the help of AI that fixes a whole bunch of this stuff. And AI comes back and gives you a choice. Says, hey, see, we've got in your organization, Baker Health, we've got, the choice of doing these 5 things. Which one sounds best? And we can tell you, we ran this experiment somewhere else and, look like these are the 3 best options for how you manage somebody. And then we can take care of, at the same time, potentially take care of excess ER visits and, what's going on in the home and drug adherence and, specialty referrals and blah, blah, blah. That if you add them all together, account for like 80% of the big problems you have in access. I can imagine that. Getting from here to there is going to require a lot of experimentation, isn't going to be quick and easy because it's such a complicated process that is running in your
right.
brain with every patient, right, that comes into your office. And,
Yeah.
you're also busy as hell. And then the other problem, which, we both referred to is if you do all that, are you somehow going
Right.
to get paid more? If you stop a bunch of expensive emergency room visits and you get them to the right specialist the first time and they get fixed, now, not in 2 years and whatever, do you somehow get rewarded or they go, oh,
Yeah.
thank you, Baker Health. You guys did a lovely job for our patient, but because it only took you,
Right.
X visits rather than X times 3, you get paid
Right.
40% less.
Right.
I don't know. So there's a
Yeah.
lot of questions about that. Like, does it work and how do we fix it? But there is
Yeah.
room for optimism. I just, it's very hard to predict how that's going to come out. And I think a lot of it's going to come down to smart people like you who are on the front lines, experimenting and advocating and
Yeah.
evangelizing what you're doing. I think there's a lot of people like me saying, oh, look at all these different things. If you did it like this, it would work. But as you said, a lot of times you're giving people a fix a point solution and now you're giving them more work and it fixes that one thing, but the knock-on effect breaks 2
Matthew,
other things.
that I think again a very honest and very sober assessment, and I really like it's coming. It's funny like talking to you,
You see me as 3 hours, I might not be so sober then.
but it's interesting. I'm having a bit of a surreal experience because like I get to like read your stuff, and I've read a lot of your stuff, and like to actually watch you, even like just to watch you thinking as you're saying, and then kind of ricochet and the thoughts. It's really it's a fun. I feel like I'm watching a cool movie, just watching like a brilliant mind tackle these like very complicated problems that I'm familiar with, so I can understand, like I can understand enough about where you're going. So it's pretty fascinating. I wonder, so I'm going to press you on some like I'm going to take advantage of that, and just press you a little bit.
Yeah.
So you're like, in some ways, I don't think someone would be wrong to classify you as a world class US healthcare historian. Like, given that's another, I haven't seen you labeled as that, but I'm gonna go ahead and just throw that out there. But you've studied, you've examined, you've been in the throes of healthcare for the better part of 2 decades, and again from different angles. And I wonder, as a historian, an expert historian in healthcare, given what we've discussed here today, and all these things that are kind of bubbling at the horizon, we know some are going to be thrown by the wayside, a la blockchain, that we're hot and heavy on, and we just don't know which one it is. And we know that there's going to be stuff that comes out of the left field, but we don't know if this like toxic beast, this what I think of as an undefeated evil beast that is our healthcare system, continues to stay undefeated despite these silver linings. And so, what do you think? Like right now, what is it? It's 2025. Like 2030, you and I are talking 2030. Cost up, quality, whatever. Or do you think that there is that like Amazon breakthrough where it's an unrecognizable? The mail system has been abolished. Like, what do you? What's I know you're not. I know
Right.
you're not God, but damn it, if you're not the closest thing when it comes to healthcare historians. So just give me your take. Don't worry, we're not recording this, and I can't throw it back at you in 5 years. Yeah.
We are recording it, and you will, but you should. But so I would first off say that on my blog, I regularly have pieces from Mike McGee and Jeff Goldsmith, who are two older, wiser men than me, and they are real historians, and will tell you why. And Mike's got a piece on my blog, I think, coming out tomorrow, which is all about the introduction of how the NIH essentially funded the introduction of angioplasty, and he has quibbles with what's currently going on with Doge. Quibbles is not it's not the right word, but but nonetheless, there are great historians of healthcare around. So for people who want to dive into this stuff, there are great people to read and look at. Yeah, in answer to your question, I had a jokey piece about the time traveler comes back from 2025 to 2010, when Health 2.0 was probably just getting going, right? Getting going to the sort of height of people really starting to pay attention, and some VCs showing up, and we were just about to put money into the High Tech Act, and the EMRs are going to take off, and we're going to build all these tools on top of it and all that stuff. A lot of excitement around that. And 2025 will come back, and after all this VC investment and excitement and new ways of managing chronic illness and new ways of developing health plans, the only two successful venture-backed companies that went public, one of them is selling selling injections to make you thinner and make your hair regrow, and the other one was selling drug advertising to doctors. And that's Hims and Hers and Doximity, which are the two most successful, venture-backed companies. And you're going, that didn't change the way we did healthcare much, right? So I'm very loath to see this. And Arnie Milstein, the great medical director, is at Stanford, was at Mercer for many years, and was the medical director for what's now the Purchasers Business Group on Health. He calls it the mother of all adaptive systems. So the track record is saying that in 5 years' time, not much will change. So that's, I think that's, if I was doing the sort of
Handicapping it, yeah.
likelihood of victory, like they have in when you're betting on games, I think 75% victory for the system and not much changes. The 25% is that I think our best hope is sort of fixing the consumer patient problem. And I think our hope is that some combination of people like you, people running specific medical groups, which are mostly virtual now, for people with specific medical conditions. I'm talking about autoimmune disease, GI groups, like OSHI, other primary care medical groups, like Firefly, and a bunch of others who are trying to figure out how would you change the patient experience and manage the patient through the system for the thing they have, right? I think those kinds of groups, if they are allowed to get off the ground and not sort of kill the birth by either big health systems or by the health plans who work with them, if their virus spreads and people start figuring out that, yes, we can manage our patients better in a way that's cheaper and better for those patients, and get a big enough sort of market share amongst those patients that their experience is better and cheaper using all these different types of technology. I think that's the thing I would be looking for, to say that are those groups in 5 years' time and those patients sort of covered by this new experience that is better and cheaper, are there significant growth? Do they go from like 3% of the system or whatever they are now to 15%? Is that part of the up curve? Do we see that in 5 years' time? And probably if you went back to look at retail in 2002 or 2003, you know, online retail deliveries to the home weren't that big a deal, you know, and Amazon stock was still in the toilet and was going, this thing's losing money year after year. Well, by that, you know, by the end of the decade of the 2000s, you know, Sears and Kmart are, you know, their stocks in the toilet and their companies are barely going because they will be, you know, and Walmart is struggling, relatively is in trouble, although it spent its way out of that because, yeah, we now have enough people on board who are happy to buy their stuff in this new way, and we fixed the consumer experience in a way that, you know, has now led to a whole bunch of other problems because of the way Amazon behaves, but at least people went, oh, I can give you $50 a year or $99 a year, whatever it is. You'll deliver stuff to my house. I don't have to think about it. Or my regular
Right.
inventory shows up, you know, and I can buy anything. It'll arrive the next day and it's cheap and whatever. So you've taken a whole bunch
Yeah.
of friction out of the system for me. I think that's the kind of that's experience. That's the kind of an analogy that, you know, I'm hoping that organizations like yours and others are starting to do. It is with the caveat that for people who use the system the most, especially who want to have hard to diagnose or hard to manage illnesses, that requires behavior change, have some dose of mental health issues, which is a big part of this, and therefore by definition are kind of hard to deal with. Yeah, that's the bit that they're really hard to move around, which is unlike, you know, getting my family to go from going to Target or whatever it was on a bi-weekly basis to just having an Amazon account and
Yeah.
going, click, I need new whatever. So that's where I think it is. My guess is this takes longer
Right.
and it's harder than we would like it to be. But what I don't know is how fast and how good the advances in AI get to be, and if something blows that up. Right now, you know, compared to where we were 3 years ago, the advances less than 3 years ago. You know, ChatGPT only came
Yeah.
out 2.5 years ago. The advance where we are now with kind of like the voice-based nurses doing interviews and talking to people and recruiting them. I mean, really fast advances. If you play that out another threefold or fivefold, you've probably got some really impressive stuff. There was actually I happen to have it up because I was looking at it. There happens to be a New England Journal of Medicine article from who? From Dartmouth about a chatbot, which actually the chatbot in the Dartmouth experience called Therabot actually exceeded and improved symptom reduction compared to human
Wow.
therapists. So, you know, you can imagine, well, if people believe
Yeah.
that, you know, you could start doing
Right.
something
And
about
like
a
the
lot
mental health
of
access
conditions. But
problem.
anyway,
Right. That's something like,
yeah, I mean, but don't forget now, I mean, you know this better than me.
yeah,
Mental health impacts so much other stuff, right? And vice versa. If you also have diabetes and
of
back
course.
pain, you probably might get depressed,
Yeah.
right? So,
Yeah.
like,
It's the real pandemic. But Matthew, you've been extremely generous with your time. I just have like a last one or two questions I want to pick your mind on. But I want to thank you for being so
oh yeah,
kind with your time. One of them's a short one. I want to just kind of spring it on you. At this point, if you had like if someone who's young, let's take an undergrad who's between like a very smart, ambitious, you know, pioneering undergrad who wants to kind of make the world a better place, and they want to do so through healthcare. And they're thinking, should I do computer science, AI, kind of tech, right? Or should I go be a doctor? And they're brilliant and kind of pioneering. You sit at that intersection. You cover a lot of tech. You obviously cover healthcare. What would be your advice? Which tool belt is going to make a bigger difference the next 10, 20, 30 years?
Ooh, that's really freaking hard. Because the smartest people doing well in healthcare are doing both. My suspicion the is that almost you can't be the doctor without doing the computer AI thing now, but you can be the computer science AI person without being without that impacts healthcare without being a doctor, because your tools will teach you or you can educate them about medicine. I do think healthcare will continue to be clinician led, just because people have, the doctors are a special type of profession. The smartest people do both, right? You run into a lot of really super smart doctors who are actually all venture capitalists these days, but have got clinical training and have got AI training, but see patients, keep their feet on the ground. That's asking a lot of people, because both of them are very arduous, paths. But I would say if you are that smart and ambitious, completely the opposite of me when I was undergraduate, try to do both. But if I had to pick one, I think that the power of the AI technology will go that, will enable you to do more than being a doctor. However, it's hard to predict what the future, given the power of AI, hard to predict what the future of, you know, being a computer science AI math whiz is, because how much will the technology do? Whereas the human element of being a clinician, laying your hands on other humans and helping assure them of, how their care is going, that is that's permanent. That's never going away. Even though we're going to devolve a lot of that to robots and to robots and
Yeah.
physical
And then
robots and to
last
algorithms.
question before we wrap up. I just want to get your take. You cover tech, healthcare, and investments. We started the conversation talking about how in my opinion, the most fundamental problem we have in healthcare is not a lack of tech, is not a lot of they talk about PCP shortages. It's really misaligned incentives, because there's no shortage of private capital, public
Sure.
capital, people interested in healthcare. There's no shortage of that, but it's when you get in and then, you're trying to go this way, but every incentive is making you go this way. And to me, that's fundamentally the issue here. And that's why, when you try to get optimistic about things and, you see a new flash, that you're like, well, yeah, but this hasn't changed. Let me ask you a question that's speaks to that point directly. If tomorrow we went socialized medicine, we're talking about Denmark, like a lot of the European first world, if we went heavy on socialization, in some ways you strip out this most fundamental problem. Now, you're going to you're going to be taking out a lot of other things, right? When you take that out, right? Because that same incentive model is what drives a lot of the capital that goes to spawn the innovation and technology. So it's a very complicated, but as we're thinking about AI and we're thinking about parachuting in solutions at a fundamental level, do you think the system we have just needs to be improved upon or ripped out and replaced?
I think, yeah, in a perfect world, which we are certainly not in, the rip out and replace will be done, right? Because the incentives are so hard to reform. Any one little reform changes, you know, results in so many other pieces going with it. And the Danes, by the way, I'm going to pick somebody. The Danes changed their system enough. They made it so primary care based. They actually got rid of a bunch of their hospitals in the 2000s and 2010s. And they did some significant changes, which really improved their overall system, because they were able to do that from a centralized, Soviet style centralized planning. The problem is they're Danes, right? So they're good at this stuff. You try that in, Turkey or the Soviet, the old former Soviet Union, there was some interesting stuff from the teams going in Moscow, by the way. We had them in a Health 2.0 conference. It was like, well, the guys are doing this stuff, and who knows how the hell that's going now. You try that in the US, and you get, you get this motherable, we're still I'm in a fight right now on Twitter with a bunch of doctors complaining about the Affordable Care Act.
Yeah.
The damn thing passed 15 years ago, and we're still fighting over, we're still fighting about it. And
Yeah.
it was a relatively minor insurance reform back then. It wasn't, it impacted about 10% of the population, if that. So I despair for doing that. I think the risk you run of doing that is that if you put in place, a centralized system, it becomes sort of winners and losers for who's generating innovation, and you don't have the amount of experiment. You have some experimentation. Look at the UK. There was a decent amount of experimentation. People trying to sell stuff to the NHS, but they didn't get very far. And there was a big excuse. You get the opposite of what you have in the US, which is the powers that be. Look, oh, we have austerity, we have no money, life is bad because we left the EU or whatever. We're going to starve the system of money, and the natural reaction is to clamp down on activity, and not to say, can we, be innovative and do more with less. And so there's a problem getting those innovative private sector tech solutions into the system. Having said that, with the amount of money we spend on healthcare in America, we should be able to do a much, much better job. And there are so many obvious, unnecessary things in our system. There are shortages, sure, but there's so many obvious, you've touched on prior authorization and the fact that we have this massive industry called revenue
Right.
cycle management, which I've never heard of in any other business, right? Which is like, how do we bill? And we have, entire venture-backed industries of companies wrestling, to try and get 2% more out of health plans. And the health plans have their vendors who are wrestling to try and pay 2% less. And we're going, who benefits out of this stuff? Nobody, but a lot of money gets cycled through these. You meet these really well-backed private equity-backed companies, and you're going, who the hell are they? And what are they doing? Oh, yes, they're rounding up billion companies, and they're, I met a company the other day which literally is trying to collect, is providing bank-style lock boxes and managing the check, the receiving of checks for physician practices, because that's just a mess. They're not even doing the billing. They're just getting the checks and doing it and reconciling it and making sure everyone got paid what they got billed, and improving revenue. I'm sure there is an equivalent company on the other end of the health plan trying to stop them depositing the checks. And you do this stuff and go, wow, you have this little microcosm going on. So I think that your fundamental question is it'd probably be better if we could throw it away and start again and put the right incentives in. But realistically, we are so far from that. Either, I think there is some hope and goodwill on the incoming or the administration's now here, I think, within the CMS to try and fix some of these incentives and do it better. But if they get thrown out in 4 years, which is, if they last that long, the next lot coming in, who knows what they're going to do, but they didn't really change much in the time they were in power under Obama and under Biden. They were they were trying to do big ticket problems. And I think the other part of that, if we go extreme to the AOC Bernie Sanders route, they'll be talking about extending the fee for service. They don't like Medicare Advantage, they don't like private care. They'll be talking about extending the current fee for service Medicare system to everybody, which I don't think we'll get to. But if you got there, that's got tons and tons of problems, which were inbuilt in 1965 when it was launched, or 66 when it was launched. So I think the premise of your question is, it's a great question. It's lovely to argue about on Twitter and on LinkedIn, but realistically, neither one's going to happen, right? We're going to have slow incremental reform to what we've got. And that probably means we don't change those incentives enough, and, we all stay depressed. Right now, if you can't tell, I'm depressed about the state of healthcare in the US. Will be for all. The only good news is that the only part that really seems to be growing and booming is online mental health therapy. So maybe that'll help me and you.
Yeah.
Everyone's working in
I think
healthcare
I think we're enacting it for each other right now.
right
Well,
now.
Matthew, I want to thank you for your time. I want to be respectful
No, no.
of your time. This was a hell of a good time, and I'm going to continue to read your stuff. I urge everybody to find you on Substack, follow you on LinkedIn and everywhere else, and some of your podcast. And
Yeah.
I would love it if we could do this conversation
Yeah.
every now and again, and
I'm
maybe whenever there's new stuff. I love picking
yeah.
your brain. I love hearing your mind.
Fantastic. Absolutely. And I am remiss. I have my THCB Gang radio show, TV show, podcast, whatever you want to call it, the show, which somehow I've let go and abandoned the first part of the year. I need to get it back going. I need to get you on that. But that's
Anytime.
fun. That's fun because you get to talk to usually a group of grumpy old men, because the younger, the younger, happier, men and women have got jobs. There are a bunch of like semi-retired people sitting around saying, "Bloody hell," But we have fun commenting. I need to get it back on. You'd be great on that, Z. So I
That sounds
look forward
great.
to that and finding out a bit more about how you are in the trenches. Making all this stuff
Sure.
better for your patients and for people, even if it's only in New Jersey. Even people
Yeah.
in New Jersey deserve improvement.
Even they do. Yeah, that's our mission statement. Even in New Jersey, they
Even in
deserve
New
better.
Jersey, we should be getting
That's great. Hey, thanks again, Matt. Can't thank you enough, man. Great to
Thank
connect.
you. Thank you. Take
All
care.
right, be good. All right, bud.